There's heaps of options, and the whole point of we have a premium vision planning session in our clinic, and the initial vision planning sessions with our optometrist, that's complimentary, and then they'll have a session with me as well following that, which there's a fee that's incurred. And the whole point of having these really in-depth multiple assessments is to make sure we choose the best option for our patients, because there are a number of options. We're really proud at Eagle Eyes to offer all the options. So then we can say to patients, these are the 4 options, but this one's the best for you. Sometimes 2 options will work for a patient, and then it comes down to lifestyle, risk stratification, side effects management, occupation. If someone's a truck driver and they're driving all night and they're really worried about glare and halos, then they might want to opt for presbyond, or they might want to opt for a mix and match approach where we're mixing and matching a trifocal and extended depth of focus, because then we're going to limit the glare and halos. So it's very nuanced, and what's really exciting is we have all this technology so we can, come up with the best solution for our patients.
What about somebody who maybe has a very high prescription, like high myopia, for example?
Yeah.
Would that suggest that you would maybe recommend one approach versus another, or is that really not a factor?
Well, it comes again to age, but in general, if someone's a high myope, I actually really like ICL over laser or over anything. So what I like about ICL for high myopes, so -7 and over, is that you're not removing any tissue. The corneal integrity is kept intact. There's limited risk of dry eye or regression or all the things that come with these high scripts, and it's totally reversible. So for my high myopes, even my young patients, even if LASIK or SMILE is an option, I always talk to them about ICLs as well, because I do think for high myopes, ICL is a great option for the reasons I mentioned. But I also use ICLs in low myopes. This is what sometimes people think, oh, ICL is just for high myopes. Not at all. I put ICLs in people with -2 scripts because they're not suitable for laser. Like they might have, formforce keratoconus. So we've spoken about this before, but it's where the cornea looks like it's a bit unstable. And if we do laser, we might destabilize it and cause long-term vision issues. So I have plenty of keratoconic and formforce keratoconic patients who clearly aren't candidates for laser, but I've put ICLs in. So ICL is actually a really nice diagnostic tool, or a therapeutic tool now, that we can treat a number of different conditions. Again, ruling in patients that couldn't have visual correction if their corneas are too thin or they're borderline for laser.
So anyone who's maybe like a chronic keratoconus sufferer, and they're a bit tired of scleral lenses, for example, then an ICL might be a really good
Yeah,
option
it
for them.
could be an option. There's also other treatments for keratoconus on the market now as well. Like
Yeah.
we've got cares and other things. The key for patients that want ICLs for keratoconic is they have to be able to refract down. So we have to be able to correct their prescription to a very reasonable visual acuity to get a good outcome from the ICL.
Mhm.
But yes, that could be an option for someone in that situation.
What about somebody who has astigmatism? So are both options still on the
Yeah,
table?
so as I was saying, so the ICL and the RLE treat a huge range of astigmatism. I think the ICL is up to 6 diopters of astigmatism, and the RLE it's even higher. And you can get custom-made intraocular lenses as well for really high astigmatism. So astigmatism is not an issue. The only one currently is the ICL Viva that doesn't have the toric version. But otherwise, astigmatism is not an issue across the board. And presbyond is also the same. It treats really high levels of astigmatism.